Welcome everyone to today's webinar, The Road to Recovery, How Health Systems Can Bring Back Patient Volumes, Recover Margins, and Increase Market Share in 2021, sponsored by BRG. I am Ayla Ellison, Editor-in-Chief at Becker's Healthcare. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a discussion and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Please feel free to include your organization and title with your question. We look forward to hearing all of your questions today. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. At this time, I am pleased to turn the floor over to Mukesh Gangwal, Managing Director with BRG, to introduce our presenters and begin the discussion.
Thank you, Ella. Thank you, everybody, for joining this call. We are looking forward to a lively discussion over the next 55 minutes or so. Please feel free, as you deem fit, to send me your questions, and we'll try our best to answer as many as we can. With that, I wanted to welcome Parveen Chand and Simon Curtis, who have been kind enough to participate in this call. Both are senior leaders in the provider sector, and their insight will be hugely valuable in this discussion. By way of introduction, Parveen Chand joined IU Health as Chief Operating Officer for IU Health's Adult Academic Health Center, which includes Methodist and University hospitals, in August 2016. An experienced hospital executive, Parveen has served as COO for Ashkenazi Health in Indianapolis and Creighton University Medical Center in Omaha, Nebraska. He has also held leadership positions with Hospital Sisters Health System and Barnes Jewish Christian in St. Louis, Missouri. Parveen earned a degree in biology at St. Louis University and completed graduate studies in health administration at Washington University School of Medicine. Welcome, Parveen. Simon Curtis is Vice President of Duke Health Access Services and Vice President of Ambulatory Services for the Duke Private Diagnostic Clinic. Duke Health Access Services is responsible for appointment and access functions by which patients and referring providers access Duke Health. The Private Diagnostic Clinic, or PDC, is the independent multi-specialty physician practice of Duke Health and is one of the first and largest faculty practices in the United States. Simon directs and integrates the various functions of PDC ambulatory services and oversees the operation, finances, performance, and quality outcome of all PDC sites and Duke Health Access Services. Simon received a bachelor's degree in chemistry from University of Richmond and a Master of Health Administration from University of North Carolina, Chapel Hill. So let's get started. Over a year ago, U.S. and actually the world really faced a public health emergency. USA has 30.9 million cases of COVID-19, 556,000 deaths. Yesterday, there were 62,004 cases and 907 deaths. So this problem we have with the pandemic has continued relentlessly over a period of time. And 60 plus million, or 20% of the population has been vaccinated. But it's still unsure. We are still unsure of where this is really headed over the next few months. In terms of its ramifications to the provider sector, $323 billion of losses for hospitals and health systems in 2020, and almost 50% of the hospitals ended the year with negative margins. So not only has it been a societal catastrophe, it also has impacted narrowly and very significantly the provider sector of healthcare. With that as a background, I'm going to ask this question to both of you, Parveen and Simon, starting with Parveen. Can you walk us briefly through organization's 2020 journey? What was the topmost challenges you faced, and what have you learned? Can you put the screen up?
Sure.
Parveen?
Thank you, Mukesh. Thank you, Mukesh. Thank you for the invitation to join. For Becker's, thank you for creating this platform, and to all of you who joined the call today for your hard work over the last year plus. If you're on this call, you know how critical you and your organizations are to the fabric of this nation. So first of all, thank you to everyone who's on the call. You know, before we get into our journey, it's good to understand where we've come from. It's important to know who we are. IU Health is the state's largest and most comprehensive healthcare system, comprised of 16 hospitals, over 35,000 team members, almost 3,600 physicians, 9,000 nurses, over 1,100 APPs. And if you look at by the numbers, we have an obligation to serve 1 out of every 3 Hoosiers in the state. That's a very, very big obligation. You know, everything that we encountered last year was really rooted in our mission, our vision, and our values. Our mission statement is to improve the health of our patients and community through innovation and excellence in care, education, research, and service. We have a common vision with one of the state's or the country's largest medical schools, the IU School of Medicine. Our common vision is to lead the transformation of healthcare through quality, innovation, and education to make Indiana one of the nation's healthiest states. Rooted in those two things, along with our values of excellence, purpose, compassion, and team, we felt that obligation to deliver on our promise. Here at the Adult Academic Health Center, our journey really began with that phone call on a March evening with the Chief Medical Officer of the state on how ready we were to really do battle with what we were seeing on the coast. You know, our background in terms of our legacy system and where we've really come from over the last 20 to 25 years really made the following possible. We had to balance the response of the pandemic with an ongoing commitment to care for Hoosiers with other healthcare conditions. And that became a necessary skill for our leaders at all levels to establish. And specifically, we went through a process of establishing guiding principles, and we had 6 guiding principles. Our most pressing priority is our team's safety and availability, so that was the first principle. The second was safety and quality of care for our patients is the core of our mission. Third is, even in challenging times, we promise to provide the best care designed for each patient, so personalized medicine. Fourth was a guiding principle of establishing a set of practices to be sound stewards of human capital and financial resources. And in that early first few weeks or so, in a time of crisis, as well as ordinary times, we established a principle of communication being the foundation on which trust is built. And finally, to manage a work demand for the next, what turned out to be several months, we will not and did not introduce any new process improvement ideas or work streams unrelated to the pandemic. So getting very, very focused. What changed for us during the pandemic, I know we've developed stronger partnerships with health departments. We've developed stronger partnerships with social service agencies, suppliers. If you remember the first 2 or 3 weeks of the pandemic's impact across the supply chain as a whole, we had to look at alternative suppliers, as did everyone else. So we fostered and developed those relationships, which I think we can continue to leverage. We have emerged with a stronger trust among our key stakeholders. We've become more focused on the epidemics within the pandemic, a raised level of awareness of how those that are marginalized and disenfranchised were more adversely impacted because of longstanding beliefs or practices. So an increased awareness of equity, diversion, and inclusion. What we've learned is that our mission, vision, and values are core. It's important to be transparent and honest, continuously to invest in our people, so let your stars shine. Leadership must inspire, simplify, simplify, and simplify, and we actually went with the 3 S's of space, staff, and supplies. Simplification was key, a constancy and consistency of message. And those are the things that I think we can carry forward in terms of our road to recovery, is just being rooted in those elements.
Thank you, Praveen. Again, just wanted to reemphasize the simplification aspect of it, reemphasize the need to serve the community on a timely and aggressive basis, all of which are very good points. Simon, love to hear your and Duke's response to this public emergency.
Absolutely. Yeah, thank you. And Praveen said it well. I'm glad to be here. I appreciate the platform. I appreciate Becker's and Mukesh the invitation to talk today, and also echo the thanks to everyone out there and all the work and commitment that it's taken to get through the last year. So, I mean, I think, the story here is in a lot of ways similar to the story that Praveen just told. I think there were some incredible challenges, and there was no roadmap for the last year. This was a true black swan event that there were some discussions about conceptual planning for, but until you're really in it, there's no way to understand the level of work and the change and the leadership required to get through something like the last year. We at Duke, I think, followed a similar path to Praveen in that we had some principles, some values that we were unwilling to sacrifice, no matter how difficult things became, and that started with the safety of our workers, safety of our patients and staff. That manifested in being sure PPE was available, no layoffs, supporting childcare, food insecurity, support, all those sort of things, and over the year evolved into some real detailed and deep work around health equity and the systemic issues around racism that were overt and more apparent or sort of as apparent as they've ever been. And I think, the question being the topmost challenge, I think the reality is that all of those things are complex, complicated, destabilizing for society and destabilizing for individuals, for our patients and for our teams. And they all hit in 1 year, not to mention a difficult presidential election and political climate that had really personal sort of ramifications for people. So I think, the culture, the engagement, the protection of our staff and teams was the biggest challenge. I think what we've learned is that the people who make up large healthcare organizations like IU and Duke are special people who can accomplish anything when faced with these kind of challenges. And at the end of it, I also think that maybe building on something Praveen said, that the reality is that large organizations, provider organizations like Duke and IU, are the point where patients touch healthcare. So there's a lot around healthcare with payers and the sort of whole ecosystem. But the role of providers in that is incredibly unique and complex, but also represents a point of incredible opportunity going forward to affect things like health equity and to affect things like the existential challenges around cost of care, quality of care, and those sort of complex issues. So I think we've proven we can take on almost anything, And I think we've also shown that there is incredible power and opportunity to affect some of these issues that have been and felt maybe insurmountable for the last 10 to 15 years that maybe now don't seem so tremendous. So I'm excited about that.
Thank you, Simon. And thank you for also bringing forward, the societal questions which COVID-19 precipitated about race, equity, healthcare as a right versus a privilege, and we'll talk more about it. Next question goes to Simon. In the last AHA report, it said that gross revenue as of January 2021 was down by 4.8%. Outpatient revenue was down by 10.4%. Patients continue to avoid non-emergent care. They're getting more and more into acute care facilities, physician clinics, and avoiding the emergency room. Discharges are down by 12.7%, but length of stay has gone up by 12.6% because of patients needing more intensive care because of delayed visit to their physician or the hospital in the COVID-19 environment. With that as a backdrop, Simon, the question to you is, how do patient volumes today compare to pre-COVID levels, and how is your organization working to re-engage patients as well as giving them greater access in your role as the Chief Access Officer, if you may? Simon?
Absolutely. Thank you. A great question. I think our trends, and generally speaking, follow sort of the national trends. I think we've seen what we're calling sort of a rebound, but not recovery of the slowdown last year in terms of overall volume. We last March, when COVID really was sort of the key focus, we had about 6 weeks where we delayed all possible sort of elective care to create capacity to be sure we were ready for any COVID patients and to sort of reorganize our operations. We said that and then realized quickly that as academic medical center, there's not a lot of truly elective care happening in our system. So, delaying a surgical case by a couple of days or even a week or 2 weeks is possible, but delaying care much beyond that point begins to be, really difficult, except in a few select areas. So we really had about 6 weeks of volume being significantly down. At this point, we're actually back to comparing ourselves to, the fiscal year 20 budgets and are doing relatively well relative to pre-COVID volume across our inpatient discharge numbers, our primary care and specialty care clinics and ORs. You hit on a key point, though. We are definitely seeing a difference in the emergency department and the urgent care world, and I think that's a national trend. Urgent care particularly has been different, and behavior has been different around urgent care. I think there's a question about what happens there, and has some of the digital options that have proliferated through COVID, has that changed patient behavior? And basically, are there things that were going to urgent cares that maybe didn't need to go to urgent care prior to COVID? So I think that change is something we're monitoring closely and trying to more fully understand. And I think in terms of our specialty services, the rebound was quick, and we're seeing a huge increase in mental health referrals and patients who are in need of mental health support. I think, that's so we're going back to the first question, a symptom of everything that people have faced over the last year. So we are doing a lot of things to creatively expand our ability to meet that need. So I call that out specifically. I think it gets back to the basics in terms of re-engaging patients. So we've done a lot of work with our patient advisory committees and those sort of things to be sure we understand the voice of the patient, and to both evolve operations to be sure that everybody is safe, our staff first and our patients as well, but then to be really visible about those things. So, we used to want to clean when people weren't around so that they didn't, sort of see that, feeling like that was kind of back of the house stuff. But now we've reorganized some of our standard work to be sure that patients and others see the cleaning and see what we're doing to disinfect and to follow through on those things. Masking, screening, all the sort of things that I think everyone is doing, I think have started to build this sense of safety when people are in our facilities, and we have sort of over the last year proven that people are very safe when they're coming back, and we're doing a good job talking about that so that people feel comfortable and confident. I'll say, I think the other piece of this is that, with digital health, we have moved things away and out of our facilities where we can. And we've really, talking about the access side of things, we've really come back to this mantra of right care, right place, right time. And that means a lot of different things. And we're, through digital health, through partnerships and other things, we're really evolving how we're evaluating getting care to people, maybe not in our facilities, maybe in churches, maybe in community organizations and other places. And I think that's been helpful. And I think the last point is just we have been working really hard with some of our payer partners around quality programs, particularly with and high-risk chronic condition populations, some of diabetes, heart failure, mental health, as I mentioned, and around colon cancer screening and breast cancer screening, to get really creative about outreach and patient activation, to your point, to help people over some of that fear. We have definitely seen cases where we really wish that we would have seen someone sooner, and we're working in a lot of different ways to outreach to patients, which in sort of the most deliberate way we've done this in the last 6 months is some of our advanced practice providers and physicians actually have participated in outbound calls to some of our most at-risk patients, and I think we've redefined our at-risk not just by disease but by education level, by zip code and neighborhood, and some of those other social driver sort of indicators, to be sure that we're supporting patients everywhere and meeting them where they are, to bring them in. So I think that's the long and the short of it on what we've been doing.
Thank you, Simon. You made a very good point on the fundamental shift in patient, clinical, and provider organization behavior leading to, as you said, the right care, the right place, right time. Which really gets into the next question for Praveen. ER is not expected to fully recover. Common indicators are that between 13 to 15% of ER care is unnecessary. Kaufman Hall has projected that 2021 lingering effect of COVID-19 would result in reduction of revenue in the provider sector from $53 billion all the way up to $122 billion in a worst-case scenario. So we will continue to see some hemorrhaging of revenue for healthcare systems. So Praveen, the question to you is 2021 an opportunity to increase market share in a tough, competitive environment by being more nimble, more agile in reopening services for existing and new patients? And what about strategically repositioning clinical services based on COVID-19 experiences? Praveen?
Yeah, thanks, Mukesh. As we look forward to the road to recovery and what will eventually be a new normal, I think it's important to recognize a number of different things in terms of COVID. One, for example, is the speed of innovation, the speed of advancement, and the speed of adoption. So one, for example, a program that I'll speak about, and there are 4 or 5 that I'll touch on. One is simply, if we looked at our distribution of services, so our 2 systems happen to be broadly defined. We have a pretty large footprint. So that distribution of services and convenience is going to be key. How do you leverage your distributed model? And for those on the call that don't have the luxury of having a large, broad, integrated network, and then it's incumbent on us to look at partnerships. So where can we provide a level of care through a distributed model? That's been one piece of one key takeaway. Second takeaway is through the innovations that happened during COVID, one of which was a response to how to take care of COVID patients at home. So our hospital at home program, for example, initially was conceived to help with the surge and increase bed capacity to accept transfers. So last March, as the pandemic worsened, IU Health developed that new program. It was hospital at home for patients recovering from COVID. And the program offers hospital-level care in a patient's home, including virtual connection to a team of home health RNs and hospitalists 24/7, continuous monitoring of vital signs, respiratory status, symptoms, and progress, a regular check-in scheduled throughout the day. And, when we launched that program, it was very, very surprising, and in some cases, not so much. In our initial 125 or 130 cases, we only had 2 readmits, and that was really surprising to us in terms of how well we were able to manage that population. So, effectively managing the risks of reducing length of stay, lowering the rate of readmission, improving clinical outcomes, reducing the hospitalizations for our at-risk patients. We looked at that and said, this is something that we now can expand on. And so when we started to look at repositioning those clinical services based on COVID, now we've taken that same program and said, can we expand that to those patients who may have a diagnosis of CHF? How can we leverage our practice from the last year to benefit patients who may have pneumonia and can recover at home, UTIs, cellulitis? So the non-COVID hospital at home program is now live. It's been live for almost 4 months, and we're already starting to see benefits of that innovation. So that's number 2, distribution of services being one, hospital at home. Simon's already touched on virtual care. We're seeing a rapid adoption among some specialties of virtual care, some as high as 50 to 60% adoption of virtual care, but it comes with challenges, and we can talk about that in a little bit. The last thing that I think that I'd touch on is how do we actually look at the innovation that most of us had to go through in terms of team-based care. And the question really now is, can team-based care be a long-term sustainable model for us? And so the jury's still out on that, but we are exploring what we've learned in terms of team-based care. But I think COVID really has prompted us to be much more innovative, to leverage our partnerships and to deliver in a different way. And I think those things can help in regards to reopening services as well as looking at increase of market share.
Yeah. I think, Praveen, you made some very good points on the delivery of care in a distributed model, in a home health model, in a telehealth model, and also questioning, the whole team-based concept, the ability for interdisciplinary rounds, etc. in a probably a more simplified and more post-COVID-19 efficient service delivery model. Moving on, let me make it a little bit more internally focused to organizations. Let's talk a little bit about remote work and outsourced work. Modern Healthcare, there was an article that 2016, only 5% of CFOs currently outsourced portions of their revenue cycle. In October 20, which is less than about 6 months ago, that number climbed to a shocking 51%. A lot of you may have read about Baylor Scott & White outsourcing 1,700 jobs, eliminating 600 to 650 jobs. R1, which is a big outsourcing company in the revenue cycle, says that they can provide the same set of services at a 30% enhanced efficiency and better cash collection by 4%. So the question is remote work for support services a long-term, low-cost option for the labor workforce? And then what is the downside in terms of institutional culture when you are not with your peers and your supervisors? So this question goes to Simon.
Thanks, Praveen. Yeah, this is a really great question and something we're talking a lot about right now. And I think there's two things. One is full outsourcing, which you mentioned, and we're doing some of that really selectively and being really thoughtful about the right expertise that we would want to outsource. I think it has to be very quantifiable, very measurable, and we can be really sort of direct and specific with vendors about what our expectations are and what the outcomes are that we're looking for, so that nobody's left guessing. And we've done that relatively successfully in a few places in the broader revenue cycle. I think then the sort of next level, and that has been at sort of the driving factor there has been at the same or better performance and at a reduced cost. We haven't seen 50% reduction in cost or anything like that, but we have been able to reduce cost in the 10 to 20% level for specific functions in the revenue cycle. The next level of that, though, I think you're calling out in the question is then remote work for staff who are potentially employed within the organization, and that is also something we had done to some extent pre-COVID. It was, of course, accelerated for our support services through COVID, where we have between IT compliance functions, some of our coding support, a good deal of our revenue cycle, our access services, sort of phone support, basically, completely, 95% working from home. The criteria we've laid out and that we laid out prior to COVID, that had us probably 15 to 25%, depending on the group, working from home or working remotely, is there a true opportunity to reduce cost in the move home? How do you manage, and you called this out, the culture, and when we say culture, the sort of the informal communication that usually leads to a dialogue about improvements, changes, innovations, and things, and a sense of belonging and sort of humanizing the work. Who's your manager? Who are your teammates? And how do you feel really connected to them as individuals in your work? And then the customer perspective, and that could be the patient. More often than not for these support services, though, it's actually the frontline, the providers, the staff who are in clinics, the clinical leadership teams who depend on them for various functions, and making sure that in a work from home scenario, we're able to still deliver what's needed from the customer in any interaction. I think it's for us, we see this as a privilege, not a right, and the expectation of delivering for our customers is the first question. we are moving towards a sort of hybrid model where we would, office share or cube share, space share, so that we are able to maintain some level of consistency in terms of the culture. We are concerned that if we sort of across the board in certain areas push towards going home to potentially save money, that the impact on turnover and FMLA and all the other sort of things that you deal with that are actual real costs to the institution would likely sort of cancel out that projected cost savings in space and other things. So we're landing on sort of a balanced hybrid model that we think will be here to stay, and we really do. We've already seen people who are seeking these sort of opportunities where they'll have some opportunity to work from home just for the quality of life, avoiding the commute, comfortable clothes and all those kind of things that are great, incredibly high quality, very talented individuals who can work in these support service areas for us very effectively. And then to the earlier point, actually get us to a lower overhead administrative cost price point. So we do see it as a long-term option, but don't see it as a broad across-the-board thing, exactly because of the culture and the making sure people feel connected, and we have that opportunity for informal communication and innovation that's so important for big systems like Duke.
Yeah, good points, Simon. On the face of it, remote working and outsourcing sounds very attractive in terms of convenience, cost, and other factors. But those are seismic shift in how you deal with your labor workforce, the ramification of which we fully don't know and understand. So those type of issues have to be dealt with more strategic, insightful response as compared to be with the Joneses response. Let me move on to the next question, which goes to Parveen, which talks a little bit more about virtual care and telehealth in this new world we live in. And one of the questions I got was that our outcomes, healthcare outcomes in the U.S. is lagging behind the rest of the developed world. So I'm going to take that portion and integrate this with this question. CMS data says that telehealth adoption by seniors increased by 50%. Wall Street Journal had an article that 1/3 of new patient visits are using telemedicine. For Stanford, 95% of the psychiatric visits were remote between September 1, 20 and March 21. Cleveland Clinic is expecting 20% of visits to be remote. So there is a fundamental shift in the location and the process by which patients are going to get care in this virtual world, which will be separated from the point of service care, which historically you, me, and others have all been a part of. So the question for you, Parveen, is telehealth transformational in nature or just a fad? And how's your organization adapting with this type of clinical service delivery model, and what does it do to outcomes? Parveen?
Yeah, it's a great question. Telemedicine is not new, and so it's been around for almost 20 plus years. Most of us probably remember our first footsteps into the virtual ICU in the early 2000s or late 1990s. We've dipped our toe, but never like we did last year. So embedded in your question is also not only outcomes, but it's also now the pressing need to really understand now with this new medium of telehealth and telemedicine, are we actually creating another gap? And so when we start thinking about social determinants of health, we start thinking about technology advancements and broadband access. are we in fact creating another gap? And I think what's important, we were very fortunate here in our organization because prior to COVID, we were already planning for a new campus. And one of the new campus requirements was going to be by the time we actually open up our new campus, how much of what we do today is actually going to be done in different or alternate care settings. And so we did almost 6 to 9 months worth of research, benchmarked with other organizations. This was in 2019, and looked across all of the different specialties like cardiology, like ENT, like psychiatry and urology and neurology, and among others, and saw a pretty wide range of what different models were projecting by 2025 in terms of the adoption rates. And so with virtual visits having now been increased exponentially, so just by comparison in 2019, we did a total of about 7,000 visits. In 2020, that was over 500,000 to almost 600,000 visits, exponential growth. One of the things that we have learned, and we continue to evolve and learn, is it's here. Most patients love it. It's convenient. Our providers actually like it, but we have a tremendous amount of work to do. We have to streamline many things, including the lack of available vitals at the point of service. We have to look at connectivity issues, as mentioned, in terms of rural America. We have to look at privacy and really monitor privacy concerns. The training of staff is something that we're learning today is all over the map. Some staff really embrace it. Other staff are are not so quick to adopt telehealth. The incorporation into the EMR, we have to at some point address cross-state credentialing. We definitely have to look at that parity point in terms of a payment. So how do we make the value proposition that a tele visit is as good as an in-person visit, and actually maybe even more beneficial, along with sustainability and training, and as well as training in medical schools. So are we educating that new workforce that this is here to stay? And to address outcomes in particular, I think it's very early to tell long-term impact on outcomes, but I do believe that with a very concerted, mindful approach as to how organizations really are approaching telehealth, I think we can get to a point to where outcomes can actually be enhanced for those chronic care conditions. Outcomes actually can be much more coordinated at a whim. For example, on this call alone, we are probably 400 to 500 people on this call. So how do we look at this new technology, embrace it, and then also look at those things that don't make it so easy, and then how do we push our system, our representatives in DC to really look at the adoption rates of this kind of a form. But it's here to stay. I think we have to focus in on quality and outcomes. That's the only way we're going to get to better adoption rates. But it's here.
Thank you, Praveen. I agree with you that there's a fait accompli to virtual care, and the measurement of the outcome of that type of service delivery will take time, but it is exciting for sure. Next question I'll ask both Simon and Praveen. And this is a very critical question on financial performance, operational performance. There's an AHA article which says in January 2021, labor expenses were 30% higher per adjusted discharge compared to prior year. PPE and other supplies and other factors have increased supply expenses by 20% per adjusted discharge. Drug expenses have gone up by 36%. So there is this vice-like pressure on costs. And even Fitch and Moody have given negative outlook for the provider sector. So I guess the question and let me start with Simon, is what lessons did we learn from COVID-19 which organizations should apply to enhance operational performance and ensure sustainability, financial, and operational. Simon?
Yeah, thanks. Great question. I'll hit a couple of things. I think the first is, again, I think the test of COVID proved what providers can accomplish in terms of change. And what you're saying, and is true, is there's a clear need for change, and cost is one manifestation of that. I think I saw some of the questions about quality of care. You could talk about life expectancy or maternal mortality and morbidity as issues that we have to take on. And it seemed that some of these were things that were known out there, but systematically we have not been addressed. I think that it is possible, and that the things that are different, I think, are just a singular orientation around what does a patient need, right care, right place, right time, and the urgency and focus from everyone everywhere across the country and across the system. This isn't just providers, to deliver on that. And, talk about digital health, talk about value-based care. There's a lot of rules and policies that providers are trying to thread the needle on relative to payer, licensure, regulatory, compliance, and all these things that in COVID, all were forced or allowed to align around doing what was right for the patient, right place, right care, right time. And I think there was proof in this work that providers, when given the freedom and the ability, will do what's right for patients by and large. Of course, there's going to be bad actors, and we need things that are going to address that. But I think it's that. It's singular focus on the patient, and empowering providers, the physicians, the staff, the nurses, the folks who are out there taking care of patients, to suggest and make change that delivers on the goals that we have around reducing costs, being better, and more high quality care. So I think that's my answer.
Thank you. Same question for you, Parveen.
Sure. Just to build on some of the things that Simon talked about, for us, it's been understanding and digging deeper and deeper and deeper into what our community and our patients, what do they really want. And for us, it's access. It's access to not only primary care, but it's also access to those specialists within our system. We also, another lesson that I think that we have to pay attention to is, how do we prioritize the work? When we had a singular focus on COVID, I think we all prioritize our work. So how does that continue to manifest itself in terms of your next initiatives or your next set of initiatives? How do you prioritize? Third is, seeking partnerships. We can't do it alone. We cannot do it alone in our communities. So how do you go about seeking those partnerships that enhance the lives of your community? A couple of other things that I'm keenly aware of now, and much more so than I was even a year ago, is the importance of those data elements and data dashboards. I mean, every system in the country was scrambling to look at real-time data in the early phases of COVID. I think that's also carried forward in terms of what we're trying to do with data and data elements. Lastly, it's also paying attention to what's happening in the world of vaccination. And if you learn from what's happening around the country with vaccination efforts, we've taken the approach of where we can then learn from those communities that still have a reluctance, for example, with vaccinations. That now can be a leveraged advantage for us downstream. So we have a deliberate effort that incorporates multiple stakeholders, from our government affairs team, our community outreach team, our congregational outreach, digital marketing, PR, and we are now looking at what's preventing people and communities from being vaccinated. So physical access, ensuring night and weekend appointments, transportation. So we've established a transportation hotline that if you actually need to get to a vaccination site, let us help you figure that out. Registration. Due to the lack of access in some parts of our market where broadband still is an issue, we are also looking at how can we be an effective communicator of information. So really understanding what the vaccine efforts are also teaching us is something else that we're paying attention to. So again, more lessons from COVID-19.
Yeah, yeah. I think as we look down the horizon, this whole area of operational and financial excellence, performance, and being leaders as compared to being laggards will continue to be a topic of discussion in the C-suites and in the overall staff strength of organizations, which leads me to, and I'm going to take some questions which have come to me, integrated with my next set of questions for both of you. The overarching questions is, what are the industry trends we are seeing, which should watch most closely in 2021 as the market emerges, hopefully, from the pandemic. So related to this shift in the industry, we talked about a little bit about artificial intelligence, automation. We talked about virtual care. We talked a little bit about supply chain. There are similar other concepts which some of our listeners are raising. So I'm going to ask specific questions to you, Simon, and to you, Praveen, which is somewhat unprepared, so here goes. One of the questions which I thought was very astute was, we talk about a need for change and concurrently increase in labor costs. So how are we going to achieve this? And in your organization, how do you manage your employee environment in terms of keeping a motivated workforce, in terms of having a lid on labor costs, which is obviously the number one cost item in the service sector like healthcare? And I'll address this question first to Praveen, and then I'll ask a separate question of Simon. Praveen?
Yeah, that's a great question. So when we look at not only the need to be much more proactive than reactive, we look at our biggest resource here is our labor force. With 34,000 employees, 6,200 of which are in our downtown facilities, it is always a challenge to look at turnover. It's always a challenge to look at that pipeline. So one of the things that we've done, and we've gotten a little bit more creative recently, and it's most likely, even I think we were headed in that direction, but it was accelerated. What we've done is looked at two or three things. One is stratification within job roles. So one aspect of that is making sure that people who are at the top of their license can actually do what their license requires them to do, or ask of them what they can do. That's one. Two is, in some respects, we are also looking at a pipeline, so establishing those relationships with other schools of not only nursing but also pharmacy, for example, or respiratory therapy, and establishing that kind of a pipeline, because I think we recognize that churn is going to happen. The third component is really around the culture, and this is why I started off with our mission, our vision, our values, is that if we can establish that culture of where trust is the foundation of every transaction or everything that we do, then how do we leverage that when we need to, in terms of why give anyone a reason to leave the organization? Now, pay is always going to be a factor, but if the culture of our organization gets to the point of where people really, really feel not only valued, but trust their leadership, I think that's one of the things that we're really, really focused on now. And I think that's going to go through 2021, where one of our biggest challenges of this year is going to be what does the workforce look like in terms of wellness? How are we really embracing our workforce, and are they available for themselves, not just for their patients? So wellness is another big key for us.
Yeah. The case for transformational change in the labor workforce in terms of diversity, in terms of safety, in terms of skills. I think all are critical questions which the healthcare provider sector will have to answer. Question for you, Simon, in terms of industry trends in 2021. Over the last few years, especially with incentives which CMS has put in terms of reimbursement for Medicare patients, we have gradually but slowly moved into value-based care as compared to volume-based care, which is represented for fee-for-service. In light of COVID-19 experience and otherwise, what do you think? What do you see in the future in terms of value-based care versus fee-for-service care? Simon?
Yeah, incredible question, and something else that we're working on and really continue to work on through COVID. I think our thinking here is that it's a core competency for a provider organization now to understand total cost of care, understand the levers that can be pulled for total cost of care, and then I think, sort of building on some of the conversation that we've had today, going beyond care, and you could call it whatever you want, but wrapping your arms around an entire person, not around just the healthcare. The social drivers of health, food insecurity, housing insecurity, all those sort of things that contribute in some ways more to the cost of providing health care in the United States. So we're deep into developing our competency and understanding through Population Health Management Office, integrating those operations into our clinics, the partnerships that were mentioned with our county, the state, actually other providers in the state. I think that's something maybe we haven't highlighted yet, but COVID with us, at least in North Carolina, represented the first time that, on almost daily basis, the leaders of all the biggest systems in our state were talking and coordinating. We were sharing best practices, helping share supplies, PPE and vaccine and other things to make sure that the citizens of the state have what they need. And I think building on that for some of these social issues is going to be important. And I think as a society, we'll have to decide who pays for what, and that might not just be the providers, but how do we organize ourselves more broadly around an individual. I think, inside of our organization, of course, we're thinking about variability in care, waste and where there is waste, so overtreatment, undertreatment, underdiagnosis, overdiagnosis, those sort of things, and then some of the appropriateness kind of work, which AI data and having some of that available at the point of care. We've seen results, and people respond to data, and people are making changes in terms of ordering and other things. Just based on an understanding of what an order might mean to a patient. And I'll say we've even gone as far as introducing the financial toxicity as a component of quality care here, so that's thought about, discussed, and understood in the same way as some of our clinical care pathways. So I think it's an evolution, it's a process, and it's, again, the key term is the partnership and working with payers, working with community organizations, and evolving our operations to meet the need of lower cost and better outcomes for our patients.
Great points. I want to be mindful of time, which we are very close to the end. But I wanted to thank you, Parveen. Thank you, Simon, for talking about COVID-19, its implications to the provider sector in the context of the employee, in the context of the patient, in the context of the organization, and obviously the mission of it all, which is good and great clinical care for the patients. So there were a lot more questions which we could not address. Please feel free to reach out to me. With that, I'm going to flip it back to Ayla to give her final comments.
Thank you so much, Mukesh, Parveen, and Simon, for that great discussion and the Q&A session. Like Mukesh said, that is all the time that we have for today, but I want to thank our presenters for their insights and BRG for sponsoring today's webinar. And thank you to our attendees for joining us today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.